currently paid as of December 31st. And I believe that's really the only qualification.
CMA, have to be CMA.
You have to be a CMA, yeah. So, those that are...
So students can't...
Not for chapter 4.
Oh, okay.
They could be
Secretary.
secretary.
Secretary, okay.
But secretary is not open at this stage.
No, it's a closed position.
Well, she's serving her second year. It's not.
You make it sound like a prison sentence.
It is. It is a prison sentence.
It is, isn't it? I beg your pardon. Sorry, Anthony.
Yeah,
No, it's
with
okay.
good behavior, you might get off early.
No, I don't think so.
Okay. Well, we're going to do this after the meeting anyways, but I think we'll probably go ahead and get started with our presentation. I'd like to introduce Tim Pearson. Tim Pearson is a provider extraordinaire at Whatcom Occupational Health. He's one of my bosses. Tim and I work fairly close together on all the bloodborne pathogen cases that come into our clinic. So between the two of us, we seem to stumble through it okay. Is there anything else you want me to?
No, that's good.
Okay. All right. Okay, so I'm going to give the floor to Tim, and he's going to give us a little education here.
All right, so what we're going to do is, and I apologize for this, our system isn't working with this system, so you guys are able to see everything. But that's fine, I don't have anything to hide in here, I don't think. So this is the latest. I've given this talk for the last 4 years and slowly been making it evolve over time, and we're going to do this again at our conference we have in 2 more months, and I've got to work a little bit. So this is a little bit work in progress, so there may be a couple of the slides that are a little goofy. I'll get going on this. So basically, I started back in the 80s as a paramedic, air rescue, then worked back down in Oakland during the drug wars. I then came back up this way. I was born and raised up in Skagit County and worked local ERs and Harborview, and worked on airlift and critical care. Then went back to grad after the ER killed my back. I went back to grad school and got my master's in nurse practitioner. Worked primary care for about 10 years, and then I ran my own business running remote clinics all over the United States, from Prudhoe Bay, out in 400 miles out in the Gulf, to basically at one point I had 17 state licenses. I've always been interested in infectious disease. When I did my master's, I actually had my own group of, I'll talk about it here a little bit down the road. I actually had my own group of patients that I took care of, and this was back during the back in the early 80s, when they had to take an average of about 40 drugs a day, 40 pills a day, to maintain or try to decrease their HIV load. And it had to, basically, if they didn't die from the side effects of the pills, they died from the HIV. Every one of my patients died back then. So it wasn't a, it was
You
a,
want
it
to
was
put
a,
that on your resume?
it was quite a, yeah, I know, it was quite a learning experience. So what is a bloodborne pathogen? It can be transmitted by blood products, or certain internal bodily fluids. In the U.S., that usually means the hepatitis B, C, and HIV in 1 and 2. We're going to start with the definitions, go to the transmission rates, and then what are the protocols for bloodborne pathogens. And then we'll have some time for questions. So, and some of these I'm just going to kind of, I'll let you guys look at it. Legislation back in 1992 was the first bloodborne pathogen standard, and they've just been building on it ever since then. It provided, personal equipment, communication, signs, labels, defining decontamination, training, and all that. Then in 2000, they developed the Needle Stick Safety and Prevention Act. So that's where they started coming up with the needleless systems and that type of thing. And then in 2001, they made the definitive directive in the treatment of bloodborne pathogen exposures.
Hey, Tim, do you mind if I play with the light?
No, okay.
Might make it a little easier for people to see. Is that better for you guys?
Yeah,
Yep.
Okay.
thank you.
Then in 2005, and they've actually just done one, I haven't got it in here yet. They looked at the alternative protocols for acute exposure to HIV and started looking at doing using the antiviral combinations if people were exposed. Back in, as you can read all my notes as well, in the mid-'80s, as a paramedic air rescue, when I was in Oakland, I took care of 2 of the original first 50 patients who got HIV. Didn't know it for 12 years. They finally caught up with me 12 years later and said, you have to go do AIDS testing because you took care of them. I'm like, really? I did not know that. Which it wouldn't be, I mean, it was a little frightening just because back then we didn't have this stuff. And so, I mean, I literally would change my clothes 3 times a shift usually because it was covered in blood. This was back during the drug wars. I mean, literally we'd walk into a room. I mean, there were times because guys would, the gangs, and this was back in the motorcycle gangs and all that type of stuff, they'd come by, see our ambulance, and bring the guy over there and then shoot him in front of our ambulance because they didn't want him to die, but they wanted to teach him a lesson. I mean, so, or we'd walk into a house and we'd hear the gunshots, we'd go walk in, and I mean, there was blood still spurting out of the guy as we were walking in. I mean, it was just crazy.
There was a physician that we had, I'm not sure if we had it here, if it was up in Canada, but he had worked in the same area at about that same time. And he said you literally wore, I'm sorry, but what we call them up here in Whatcom County and Skagit County, barn mucking boots.
Yeah.
In the ER and rubber.
Yeah. Yeah, I had military.
Aprons and all that sort of stuff because, and he had to be tested every 6 months.
Yeah, I got, once they found me, I was tested for, I don't know, about 8 years, 10 years, somewhere like that. Then they made the guidelines for the dental offices.
Do people really think about offices as being possible?
Oh, it's one of our main ones.
Oh, well, I believe that's true.
It's
but
what
I'm
we.
just saying that I'm not sure that the general public.
No, but it's one of the main. That's one of our main patients are the dental offices. We see them a lot. They're always poking themselves.
Overseas, Hep C is spread quite a bit through dental offices.
Yeah. So what is covered under the bloodborne pathogen exposure? Body fluids, blood, cerebrospinal fluid, pericardial fluid, which is the heart fluid around the heart, pleural fluid, the fluid around the lungs, vaginal fluid, and semen. Peritoneal fluid, which is the surrounding the gut, the joint fluid, amniotic fluid, and then breast milk. What's not covered? Saliva. You cannot get infected. It's really no way you can get infected from a bite or coming from the mouth. Vomit, because of the acid from the stomach, kills the bugs. Urine, for the most part, unless they're really, really sick, you can't have anything in the urine. Urine is sterile. Feces, I mean, it's just gross, but you could sometimes catch hepatitis if it's really infected, but that would be a rarity. And then tears, because tears have all your natural, I call them the killing factors in it that you can't really get any infections from it.
Hey, Tim, I had a question. You mentioned about bites and saliva. If the bite breaks skin and causes bleeding, and if the person who's biting has bad dental work or something and it's got blood in his mouth, is there any?
Still very rare.
Yeah.
No. Because you know, if you think about it, what's the one area on our body that is open to everything? It's your mouth. And so there are so many there's so many antimicrobial stuff in your mouth. Yes, humans have dirty mouth. Yes, you're not going to get infected with hepatitis B, C, and HIV in 1, 2, but you can get infections from getting a bite. But you can't get infected with hepatitis B, C, and HIV 1 and 2 unless you just had terrible mouth and you had sores all over your mouth and you got a bunch of blood squirted in your mouth somehow or something that's a positive HIV patient. Maybe, but it's very unlikely. If blood gets on intact skin, it's not an exposure. There has to be an opening in the skin, a major opening in the skin. And then again, with all the body fluids not covered, however, if it's mixed with blood, then we run it as a bloodborne pathogen exposure. Preventative measures, universal precautions, isolation, careful handling, disposal of sharps, safety syringes, protective clothing, and then also sharps containers. And that's the thing is, as Dave can probably tell you, I yell at people all the time. What's the number one thing that we have people coming in for? Capping a needle. You never cap a needle. Never. Should I say it? Let me say it again. Never cap a needle. I mean, truly, it is the number one thing we get, and that's what happens from all the dental offices. What happens in, with the out in the nursing homes. And particularly the insulin needles. Those go right through the cap, and that's probably, I would say, probably 60% of our bloodborne pathogen exposures is trying to do an insulin needle, which we have to run it just because they got poked, but it's really not a bloodborne pathogen exposure because insulin needle, the way it works is you don't draw back on an insulin needle, you push, and so when that happens, all of the pressure in the needle, there's no blood that can come back up into it. And so it's really not an exposure. But since it's under L&I, we run it just to run it through. Immediate care after exposure, stop the bleeding, clean it, soap and water. Don't use acid, don't use bleach, don't use hydrogen peroxide. All those kill healthy tissue. And clean the contaminated areas. If a small amount of blood gets on the intact skin, there's less than a 0.1 chance of any type of infection. There's no documented cases of HIV transmission due to skin exposure. Big things is any type of wound, you irrigate it under running water for 5 to 10 minutes and clean it with soap and water. But you don't use any of the other stuff. Risk of transmission to healthcare workers. Look at the type of body substance involved, route of exposure, volume of blood or bodily fluid, severity of exposure, pathogen involvement, degree of viremia, and immune status of an employee.
Tim, I want to play dumb and say, what is viremia?
I was just going to answer that. And so viremia, the way to think about viremia, it's the amount of pathogen in a person's body. And for the most part, it doesn't play a big part, or doesn't play a big, huge thing in bloodborne pathogen exposure, with the exception of, and it's not as present as it was back in my day, back in the 80s and 90s, because we didn't have the drugs to take care of HIV and hepatitis then, or not as good as we have now. And so there would be there were people walking around with large amounts of virus, and I mean, huge amount of virus in their blood. Versus now, most of the known HIV AIDS patients, they have zero, because just taking one pill knocks it out, where back then, you know, we had to do 40 to 50 pills to even get it down somewhat. And if they miss a dose, then they become resistant against it, and then they have to find another dose to go against it. So it's not as present. Viremia is basically the amount of pathogen. Factors affecting transmission, deep injury, which would be just at the very bottom, you know, is usually like an artery or a like arterial line or something of that sort that you got poked with. The deeper it is in the body, the more potential it is to have a bloodborne pathogen. We determined the severity of the exposure, type of quantity of fluid, depth of the wound, mucous membranes involved, open skin, you know, and that's where if somebody, like oftentimes happens, somebody will get some, had an IV line and it squirted and it got them in their mouth. You know, so I take a look inside their mouth, and everything looks intact. It's done, not a bloodborne pathogen exposure. So starting post-exposure prophylaxis, if indicated, no evidence expressing blood, by squeezing the wound will reduce your risk. So don't bother with it. Just washing it. With percutaneous sharps exposure, the risk of HIV infection is less than 3 in 1,000 people. Again, there's exposure to intact skin is not a risk, and bites have never been implicated in a transmission.
Statistically, too, I think this county is one of the lowest rates in Washington.
Yeah, it's pretty low up here. Treat the wound. So what do? We treat the wound, determine tetanus status, and with L&I, they just, for reasons I'm not quite clear on yet, but I think it's just to, basically it's their population is, if you have a bloodborne pathogen exposure, we give you a tetanus, if you need it. Counsel the employee, determine the hepatitis B vaccination status, and so that's one of the tests we test for, is when we do your HIV 1 and 2, hepatitis B, C, and HIV 1 and 2, and then we also check your hepatitis B immunity screen to see if you're up to date, and because about 3 to 4% of people don't respond to the hepatitis B series. And so if we find that you're a so-called non-responder, all that means is your body's not showing it the way it's supposed to show it, but you do have immunity. So if we find that you're equivocal, they call it, or not immune, then we'll give you the hepatitis B series over again, but then we're done. We don't test it after or anything because we know you have immunity. You're just, for whatever reason, your body doesn't show it. And protocol for testing is that we do baseline, so whenever you come in the first time, 6 weeks, 3 months, 6 months. We don't instigate prophylaxis PEP is post-exposure prophylaxis, unless there's a really, really high suspicion. The ER is a little bit more aggressive with it, but truthfully, over a third, well, we have it as, on this thing, over a third of patients discontinue due to side effects from the medication. I would say it's probably 75%. It makes you sicker than a dog. I mean, in 4 years, I've had one patient make it all the way through the course. I think I've started probably 7, maybe 10 at the most. Yeah, it's pretty awful stuff.
The PEP also, if I recall, is time sensitive because you have to start it within a certain amount of time. And it's
72 hours.
expensive. It's really expensive.
Yeah, we're talking, one course is, I want to say $2,800, I think, or something of that sort.
But if you were hurt on the job,
L&I pays for it. Yep.
I mean, I'm just working.
So and then we work on, we arrange follow-up care. When donor and source is unknown or at high risk, we test the exposed individual. And then if the donor is negative, we test both, we call it the source, or they call it here donor, but we call it the source. And if they come back negative for hepatitis B, C, and HIV, we're done. Because you can't get infected.
Okay, I have another question. And this is
Just ask the question.
maybe a little sensitive in the fact that, do they test people that go into Whatcom County Jail on a regular basis for HIV?
Yes.
Thank you.
Yep, they sure do.
Thank you.
One thing, if you're ever involved with a bloodborne pathogen incident, always try to get the source to provide a sample. They're not obligated to, they can refuse. But it's so much easier on the person that's been exposed, because if the source refuses, then they have to go through 6 months of testing, getting poked all the time. But if they agree to it and they're negative, then you save that person from having to come in all the time getting poked.
Yeah. There's a thing called seronegative, and that was where I was getting back a little bit ago. The seronegative means they do not have a response to the infection, and that's oftentimes with somebody with significant HIV or something like that. It's completely knocked out their immune system. But again, that's pretty rare nowadays, just because there's they're so good at getting patients who have HIV at least on one drug, and so it's pretty rare. It's very rare, but it's more common in Africa. What are bloodborne pathogens? So like we talked about, hepatitis B, C, HIV 1 and 2, malaria, syphilis, viral hemorrhagic fever, which is not good, arboviral infections, Creutzfeldt Jakob disease, which is mad cow disease, which was going around England here a few years ago. Relapsing fever, human T cells, infotrophic virus, HTLV virus, leukemia, lymphoma, and then Ebola. Infectivity rates. Hepatitis B, 20%, or 20%. Hepatitis C, 2% probability of any infection, and HIV is 0.3%. So it's pretty difficult to get. Hepatitis B is the most common. Progression to chronic disease. Hepatitis B, it's the least common to progress. Hepatitis C, it's 80% of people who will progress to a chronic disease. And then HIV 1 and 2, 95%. So this talks about the virus. So HIV virus. It's a retrovirus, so their genetic information is encoded by the RNA versus the DNA. Retroviruses use a DNA polymerase. It's just a different type of RNA that directs the synthesis of the DNA to form the viral genome once it infects the host. So it kind of fakes it out a little bit. Multiplies rapidly in the blood, develops resistance rapidly to drugs. And that's why HIV has been so difficult to treat. Because just like back in the old days when they were having to take 40 pills a day, if they skipped 2 or 3 doses, they became resistant to it because the bug would become resistant to it. And now we had to try to figure out, and they were already on every single medication that we could put them on, because we didn't know how to treat it any differently at that point. And so it made it very, very difficult. Therapeutic goal now is to reduce the viral load to 0, which we can with minimal toxicity and maximal simplicity. You still get sick from some of these, the newer ones, but they're combination now drugs, and they just come in kind of a horse pill, like size of a Scepter antibiotic or something of that sort, and it has 3 different drugs in it and 3 or 4 different drugs in it, and it works great.
Do they still use the term cocktail for that stuff?
No, because right now it's only a 1 pill. Yeah. Back then it was like they had people back then in the 80s. Early 90s, they had difficulty with eating because, well, 1 is it would make them sick, but 2 is they were taking 40 pills a day, and so it was filling up their stomach. So I'm just going to zoom through these. I've actually, in my other system that I have in my other system, we've taken out all these charts because they're back from 2008, and I've replaced them. But all it shows is diagnose who gets the most. So male-to-male sexual contact here, heterosexual contact 15%, 9% injection drug use, and then male-to-male sexual contact and IV drug use here, where with females 84% is due to heterosexual contact. That's why when you go on a date, if something happens, you're screwing everybody that they've screwed like for the last 20 years. So, excuse my language, but that's the best way I can put it and get it across well.
Yeah.
As Dave knows, I'm not too good at. I kind of speak it what I think. Diagnosis of HIV infection among adults. You can see top line, African Americans, blacks were the main one, whites underneath that, and then Hispanic and Latinos, and then American Indian, Native American. But this line actually, in some of the stuff I just had for recently, they're actually gaining quite a lot in the Alaskan and American Indian and Hawaiian.
And that's what's reported. Not every state reports.
Yeah, not every state reports.
And not everybody gets tested.
Yeah, exactly. This is these next two. Let me see, is it this one? Yeah, it's this one here. So the green line is the diagnosis. So you can see, back in the time when I was down in Oakland, down in this area here, you're looking at 88, 89, and you can see how it dramatically raised up. Then deaths, because it took them, would take them a couple, anywhere from a year to 4 or 5 years to die. And so you can see how you had the peak of the deaths there. But then what happened what happened here? That's when we started coming out with all the drugs. And so we saw the diagnoses, went up, and we were able to get control of them, but the deaths went way down because of all our pharmaceutical industry, basically. All right, we've already gone through this. I don't need to go through this, and don't need to go through that. Okay, HIV incident prevalence. Living with HIV, 32.9 million. New infections, 2.7 million. Adult prevalence, about 0.8%, so less than 1%, basically. Deaths, 2 million throughout the world. If you take this in context, though, I'm a major infectious disease kind of everything, all that type of stuff really interests me. Influenza every year kills over 3 million people worldwide. And the bird flu in 1918 killed over 50 million people. In fact, what stopped World War I was not because they wanted to quit fighting, is because Germany, England, France, and some of the Americans as well, they ran out of people to fight. They didn't have people to fight anymore, and so they basically all got together in a room and said, "Can you fight? Can you fight? No. Well, I guess we better stop this thing." That's basically what it came down to. And there's some pretty good books about it. I mean, they basically kind of, they didn't have phones back then, and so they basically had to go sit together and say, the generals, it wasn't the higher ups, it wasn't the main leaders, it was just the generals kind of got together. They would, just like, Armistice Day, during World War I, when the Germans and the English got together and had a big party and dinner and that where they were battling, and for 36 hours and got all drunk together and partied and all that type of stuff, and then they went back and started at it again. Well, all the underlings got together and said, "We don't have anybody left to fight. Everybody was in the either dying or had the flu so bad they couldn't do anything." So worldwide prevalence, over 32 million cases worldwide, 65% of all cases in sub-Saharan Africa, 10-15% in Asia. Got about, I think this number is it's a little less now, 5,000 to 10,000 cases in Washington State. It's still averaging about 200 cases in Whatcom County. I've been watching Ebola for over 20 years. The guy I kind of studied under for the infectious disease here in the county, he was really big on it, and so he was the one who first introduced me to it. And it's been very interesting to see the evolution of how that's gone since back in the 90s. In 2012, a really good book, if you're interested in infectious disease, came out called Spillover, Animal Infection and the Next Human Pandemic by David Quammen, Quammen. And it's really good. And they go all the way through that book, and they've narrowed it down to where HIV came from, to a 32 square foot mile area in the jungle between two rivers in Cameroon. And they, by genetics, of going back, DNA genetics, and going back and back and back and figuring it out. There's been 12 outbreaks of spillover since 1908. And the first occurred probably when a hunter killed a chimp and ate it raw or got blood on a cut or something. Then it went from simian HIV to human HIV. And then this is the biggest thing. It spread in the 1920s because Europeans decided to do the nice thing, and we had to cure all the all the tribal people. And so they started giving them immunizations. In fact, one doctor did over 5,000 injections with 6 different needles. And so it then infected all those people. Then it spread from Africa to Haiti for that reasons I was just talking about. And the reason it moved to the United States was what was one of the biggest businesses back in the 80s? That was blood plasma. And where did they do that? Haiti. And so where was their main buyer of blood plasma? The United States. And that's how it probably got into the United States and the AIDS epidemic. Let's see, we'll go through that. So basically what I already said, why the difference in death rates between all that was because of the pharmaceutical infrastructure. Why there's so many deaths in Latin America and all that type of stuff, but you look at North America, everybody else is 63 to 100,000 deaths, where ours is 23,000 deaths. So what are the most rapid changes in HIV cases? Eurasia, because of the heroin use. Russia, they've gone from 200,000 cases, went from 2,000 cases in 1997 to 200,000 cases in 2000. And that was all due to HIV drug use.
I can tell you more than that, though, because I've been to Russia a couple of times. Their hospitals, I was in the schools. There are so many rats in the schools that the cats are in the schools and defecating.
Yeah.
Again, I know they don't spread AIDS, but I also know that when we went with a group and we carried our own needles because you could not get a clean needle in a hospital in Russia.
Yep.
And so they're going from bed to bed.
Bed to
with the
bed.
same needle.
Yep.
So it spread in the hospitals.
Yeah.
And we were there in the 92 and 93 and 95 we were there, and it was pretty bad.
Oh yeah. So particularly in Russia and in the Balkan republics and all that type of stuff, just like what she was saying, they need clean needles, education, condom distribution. In the U.S., primarily it's through needles, homosexual sex, and increasing now heterosexual sex. Now, and this was back a few years ago, now it's pretty much mostly heterosexual, sexually transferred. In second and third world countries, it's heterosexual sex and transfusions. That's because they have more skin disease, allowing for blood-brain transfusion, and then prostitution, multiple sexual partners, virulent strains. And there's a cultural attitude against men wearing condoms in Africa. Congo and Botswana, though, they have a really aggressive treatment. Also Uganda, abstinence and condom use helps reduce HIV. New laws in Uganda back in 2014 legislated that homosexual males would be in prison for life if found to have HIV.
Wow.
So HIV exposure prophylaxis. High-risk exposures, puncture wound from a known positive, and usually with some type of a deep needle, like an arterial needle or something of that sort. You consider the prophylaxis, but again, you can get pretty sick from it. But high-risk patients, such as somebody known HIV and that they're just trying to spread it and that, they can't refuse. They can take it, they'll get a court order and get the blood from them. Like I said earlier, even with new protocol, patients have significant side effects, less than 50%, and like I said, I think it's closer to 75. fail to stay on the course. So we base it off exposure risk based on status of the source, level of virus, quantity of the bloodborne pathogen, and the site exposure. HIV vaccination, see, this is one of the ones I'm going to take out. There actually is an HIV vaccine now that they're using in Africa, and it's actually doing pretty well for preventing HIV infection. Sub-Saharan Africa is home of 2/3 of all people living with HIV/AIDS, and the main driver being unprotected sex. They're increasing at about 37,000 South Africans a year. Almost 20% of all the South African adults have HIV. Young women are twice as likely to be infected as young men, and they are coming up with they've actually come up with a vaccine, and it actually is looking pretty good. Advice to prevent secondary transmission after exposure: use sexual abstinence or condoms to prevent secondary infection until you know what the source is. Refrain from donating blood, plasma, organs, tissue, or semen if infected. Consider temporary discontinuing breastfeeding while on antiviral drugs. So hepatitis C, it's an RNA virus. May be viable up to 7 days at 4 degrees centigrade. 30 to 35% have no acute illness, and some of them don't even know they got it until 10 years down the road. Has a high spontaneous mutation rate. Incubation is 15 to 160 days, usually 6 to 7 weeks. It's the most common bloodborne pathogen that we have in the United States. This is kind of one of my favorite slides. So what are the risk factors for hepatitis C? Contact sports, a 3. So pedicure, manicure, 1.7. Beauty treatments, 2.0. Admission to medical wards, 2.1. Tattoos, a 3. And it is the second, so a 3 out of 5. It is the second leading cause of hepatitis, are getting tattoos.
Wow.
We've had, I think, 2 so far in our clinic that we figured out was from tattoos. Hepatitis C treatment, pegylated interferon, and then several other drugs. Has really good results at 2 to 3 years. You get kind of body achy and that type of stuff from it, but they're a lot better than a lot of the HIV medicine options. Transmission, IV drug use, transfusion, organ transplant, homosexual sex, heterosexual sex, and then large proportion, there's no known cause. Because remember, it can live for 160 days on surfaces. That's the importance of universal precautions and safe sex practices. And back to this says it a little bit more nicely than I said it earlier. You're not only having sex with your partner, but with all your other partners in the past. This just goes over some of the infection rates. Don't need this one. Baseline testing. So we check hepatitis B surface antigen, hepatitis C antibody, hepatitis B antibody, HIV 1 and 2, and then you check the hepatitis C at 2 weeks. And we've changed the way we do it, and we check at baseline, 6 weeks, 3 months, 6 months. source donor testing, HIV 1 and 2, antibodies, hepatitis B, hepatitis C. And then hepatitis 2, that's a less virulent hepatitis, does not progress to AIDS, and mostly confined to West Africa and India. Hepatitis B, so it's a DNA virus. Similar ones, and this is where you can actually get hepatitis B from ducks, woodchucks, tree squirrels. It's not as much around here, but back east, it's really rampant. There's a lot of druggy squirrels and ducks. Again, similar type of thing. Incubation period's a long time, up to 180 days. Can lead to cirrhosis, hepatitis cancer.
I knew that Rocky the flying squirrel was flying all
Yeah.
night.
He came from the other side of the
So what do we do? Post-exposure prophylaxis, we give hemoglobin, we call it H-big, hemoglobin B, and it gives 3 to 6 months passive immunity. And hepatitis B is excellent, and we don't know how long it lasts because it's still continuing. I mean, as far as we know, it still continues.
Which thing I don't understand is sometimes we're testing people who've had the immunization and it comes up equivocal.
Right, and that means that's again from earlier, that equivocal means that it's at that edge where, yeah, it's probably immune, but we don't absolutely know that, and so that's why we just give them the whole series over again, and then we're done, because then we know they're immune. We know they'll have a response. It's just basically their body is not showing what our lab is supposed to be showing for whatever reason. It's about 3 to 4%. People with chronic hepatitis infections, we treat them with platelet interferon. It can make you pretty dang sick. And so ribavirin, it works pretty well. Also, some of the other, actually, they use these actually with HIV patients as well. They're antivirals, and they work pretty well. But again, you don't feel too well doing it. Source of hepatitis infection in sub-Saharan Africa, prenatal, and contact among toddlers. IV drug use in the United States is the main one in homosexual, heterosexual activity. Transfusions, hardly at all anymore. Very, very rare. So what do we do with the protocol? Address any serious injuries, obviously. Report to your supervisor during the working hours. You come to our clinic. If it's after hours, you go to the emergency room.
We get all of the.
And then they'll
get all the referrals from the ER.
Then they'll send it over to our clinic from the ER. They'll do the initial blood work. High-risk exposure must be treated in the first 24 hours with HIV drugs. Like I said, the ER oftentimes does that more than others, but they're even now not doing as much because it's very, very expensive. And then I don't have a slide here. My other one that I'm going to add in to my new presentation that I'm currently working on is for Ebola. Because it's out there. Luckily, it's not here, but it's out there. And they've actually, in Sierra Leone, and this is kind of ironic, but Sierra Leone, they just 2 days ago said that Sierra Leone was completely free, and that was as of last Friday, was completely free of Ebola. and they've been giving a Ebola vaccine, but they kind of had to stop it because they hadn't had an Ebola case in over, I think it was 2 months or 2.5 months or something like that. So they thought they were out of the water. Monday, they had an Ebola case. So, but it's difficult, back there, just because, and you read that book that I had talked about, David Quantum's book. The problem is that we don't know where it's coming from, but they think it's coming from the simian virus, the monkeys, and where do people get their food? Well, they get it out in the jungle, and they're eating monkeys and gorillas and all that type of stuff, and so they really don't know what what is the number one source. Where is it down in the ground somewhere? Is it buried in a cave somewhere? They don't know that. They know the area, they know where it came from, but they can't figure out what is the ultimate number one source where everything comes from. And so until they find that, they're going to keep popping up with these little ones here and there, and it'll probably, I'm guessing from now on, will be just part of life in Africa. And hopefully not here. Last take-home comment. Every employee must take responsibility for bloodborne pathogen exposure protection. Do not cap your needles. Do not cap your needles. That's why they have all those little jugs put on the wall in every room and every hallway and all that. You take it, you drop it down. Hand washing hygiene, and like I said, disposable needle containers at the work site. And if you see one that's 2/3 full, that needs to be dumped. Because what happens is people go pink like that and throw it in, and it goes pink. And we've had several of those, particularly in the nursing homes. And so I've had to do a little bit of yelling at some supervisors. And always wear a gloved hand. You always have a gloved hand when you're doing injection, because Dr. Beiser here, infectious disease for Whatcom County, she's basically said, with somebody with a positive HIV blood-filled needle poked through a gloved hand has less than a 1.5 million chance of getting any type of HIV. Yeah. Through a gloved hand, that's the key. Because the gloves are made that way. There are 3 different layers. There's one going this way, there's one going this way, and there's one going this way. And so as the needle goes through, it wipes off the blood as it goes through the glove. So that's why you always wear gloves when you do a needle injection. That is it. Questions?
Pregnant moms who are HIV positive.
Mm-hmm.
I just had watched a webinar. There's drugs now for that.
Mm-hmm. Yep.
That was very.
Yep. Some of the and even some of the ones they're finding some of the older HIV drugs, even the ones that made them sick, but they cut down they cut the amount of drug in it by a couple thirds, and so you're giving like a little mini dose.
Mm-hmm.
Yeah, and so it's and because what's nice is it's not as expensive. Of course, the pharmaceutical they're making ones that are really expensive as well, but they're finding some of the older ones they can cut the dosing, cut the drug down, and treat it. Anything else? All right. Well, thank you.